Only slide is coming.
It's not online, no?
It's online. This is English.
Let's start.
என்னோட பேர் தெரிஞ்சிச்சு previous.
Can we start, sir? Okay.
What are you on?
Should be on laptop. Okay.
Can hear me. Sagar, you can hear me?
Yeah, I can hear you, sir.
Okay. Right, can we start, Sagar?
Yeah, please, sir.
All right. Good evening. This is Dr. David Rajan from Ortho 1. I welcome you all for this session of treatment of pediatric flat feet. Pediatric flat feet is nothing but a flat foot for the children. This is going to be dealt with by Dr. Vidyasagar, a pediatric orthopedic surgeon. He is also a foot and ankle surgeon. So he's a very right person to talk to you about flat feet. Very often, a lot of patients bring the children or grandchildren saying that he has or she has a flat foot. What to do? We are worried. Most of the time, there's no need to worry. Now you will listen to Dr. Vidyasagar for about 10 minutes as to what actually flat feet are, which is the one you should be worried about, and which is the one you don't have to worry about. This will be followed by Mr. Ganesan, HOD of Physiotherapy Department in Ortho 1, and he will demonstrate a few exercises for such children. This will be followed by a question and answer session. So let us start. Over to Dr. Vidyasagar on his brief talk on pediatric flat feet.
Thank you, sir. Good evening, everybody. Thank you for participating. Pediatric flat foot is one of the common conditions that we see in our outpatient department. Parents and they bring their children with a lot of concern, saying that my child foot is not normal or my child foot looks abnormal. And many times when we ask them, have you seen anywhere, when you seen any other doctors, they tell us that they have concern They have consulted, but the thing is, they're not sure, they're not given proper knowledge or the proper information yet. They're still confused. So for that reason, we thought we will give a common public awareness talk of this very common condition called pediatric flat foot. So as I told, most of the times the children will not have any problem. They'll come along with the parents. When we ask the question, put the question to the child, what is your problem? They say, I don't know, I have no problem. But when you ask the parents or the grandparents, these are the things that they keep telling. Most of the times it is that somebody else, a third party, told me that my child's foot doesn't look normal or it looks funny and he walks also differently. So that is why we brought him here and they advised us to get it treated early. And some children, maybe around 20 to 30% of the children with a flat foot may be associated with obesity. So along with the obesity, because of the obesity itself, there may be little clumsiness. So the parents are worried about that as well. And very intuitive parents and grandparents who have observed their child, they may observe that the child have to keep changing the shoes very often. They keep wearing out on the inner side of the shoe or the footwear. And they're very worried about that also. Why he doesn't have an equal wear out, he has only on one side. So these are the common things. And very, very rarely only they come to us with a complaint pain. I put that in the capital letters because that is the red flag. A child with flat feet having pain is something we need to further evaluate. And also, some children, because of the obesity, because of the flat foot itself, they may have some tendency towards having a knock knees. That's why we call it a genu valgus. Their knees may be knocking together when they are running, when they are walking. So when you ask for about pain, this pain can be like some people it may be very localized pain, some people it may be very diffuse pain. That means like vague pain. That too is not everyday affair. Some days they would have played a lot in holidays or when they had some cousins came over, so they may play a lot, or they're gone for shopping. Those are the days they may have a more pain. But when you ask for the pain, can you localize it? Very few children or very few parents can tell us very clearly that this is the area. They may say that it's a diffuse pain, and with a little massage and rest, it goes away. So that is a one very critical point that to be thought about and to be kept in mind. The second thing is when we examine a child with a flat feet, very often missed out in a general orthopedic clinics or even in family physician clinics is that tight gastrocnemius. It's a very common association, so we need to be aware of, and also we need to check for this tight gastrocnemius. And when you are checking, evaluating clinically, when we check for two types of flat foot. For the public awareness, I want to tell you that it is called, one is called flexible. That is, as this picture shows here, that is when you raise the toe. When you raise the toe, the arch forms. That is called a jack test. So the plantar fascia will pull the arch up, it forms. That is, we call it a flexible flat foot. Or you ask the child to stand on tiptoe. Again, that time also you can see a arch forming. But there is other variety, very rare variety, is called a rigid variety. That is, in jack test or when you ask the child to do a tiptoe, they may not have an arch forming. So it is fixed flat foot. So more often, this is a rigid flat foot that the child will have pain than a flexible flat foot. And after that, the X-rays are only for not a decision-making purpose, but it is mainly for to look for the progression of the deformity. If on day one we may take an X-ray, or sometimes if the child is totally asymptomatic and it is below 6 years, and below 6 years we call it a physiological because actually the arch starts forming in children only by 6 years. So any child that brought to us before 6 years, we pacify or we calm and we tell them that we make them understand that every child below 6 years will have some amount of flattening. They start having arch forming and they start having an arch only after 6 years. And also at the same time, we examine the parents. If one of the parents is having a flat foot, there is a chance that this child may have this flat foot even into adulthood. And both the parents are having flat foot, there are much more higher chances that this child may have further into his adulthood. And also, by looking at the parents, we can also look at general natural history of this flat foot. So if these parents are not having any symptoms, the child also most probably may not have any problem. But they're not worried about that. They're worried about the appearance. So many of the times, it is just a simple understanding that it is a physiological up to 6 years, and 20% of the normal population have this flat foot into the adulthood. And if it is asymptomatic, nothing much to worry about. So what we do for this, if the child comes to you with a painless, flexible, which is very mobile flat foot, and child doesn't have any problems, parent says only its appearance or sometimes occasional pain, we don't do much. We just tell them that you just continue to wear whichever is a comfortable footwear that you continue to wear, and then you just review with us maybe once in 6 months or so, because most of these patients doesn't need any treatment. And if the child is progressing from the last visit, from this visit, it is worsening, then we may give an arch support. Third thing is, if the child is complaining of pain very often, as the child crosses to 7th year, 8th year, 9th year, child may be more active, and that time if they have pain with the activity, pain with the exertion, that is the time that we give a arch support. So some parents will ask, do we have to make them custom made? But I tell them, and many literature have shown that there is no need to go for an expensive custom made middle arch supports. Just off the shelf, readily available, ready-made, ready-made available orthotics are just as good enough as the custom made ones. So no need to go for expensive ones. You can use even the ready-made available ones. And the other thing that is most important is that we have to see the association of the gastrocnemius tightening, gender Achilles tightening. So most of the children, 70 to 80% of the kids will have that. And we have to stretch that. So, but here, the stretching of the gastrocnemius is a little tricky. That technique have to be learned, that technique have to be practiced, and that technique only have to be done. If you if you do the gastrocnemius stretching by just dorsiflexing the foot, sometimes there can be a break in the midfoot, and there can be an abnormal forces that you are exerting on the midfoot level. So every parent should learn the technique and should spend time with the physiotherapist and learn that. Anyway, our physiotherapist, Dr. Mr. Ganesan, will explain that in later. And does every child needs a surgery? No, very few, maybe 5%, I'd say, 5% of the children only will end up in surgery. When we operate, it is only when the conservative treatment is failed. Conservative treatment, when the child presents with a occasional pain or a painful flat foot and on exertion, most of the time they get improved with a conservative management. That is arch support, rest, and mild analgesic, maybe few days, and then, or sometimes even changing the sport or changing the activity. That itself can have a lot of good impact on in the alleviating of the symptoms. And the tight Achilles, it can be stretched. It is good. All the children with the pes planus having the flexible flat feet or rigid flat feet go through the exercise regimen. It can be alleviated. But when there is a failed treatment of conservative treatment, then that's the time we operate. Or sometimes you give orthotic and the children may not be able to wear it. Their pain is increased, or sometimes a progressive deformity. When we compare the first visit to the 6 months visit or a later visits, when the deformity is progressing, that's the time we may operate. There are multiple procedures are described. I'm not going to explain all that here. And there are bony procedures that we operate on the bone, and there are soft tissue procedures to balance the soft tissues. But whatever the procedure may be, but these procedures will take on an average about 6 weeks of recovery time, 6 weeks to 8 weeks. And within the 6 weeks to 8 weeks, most of the time the child cannot wait there on that particular limb. Other limb we can use and use crutches and hop around. So generally we tend to operate these children during holidays time so that once the school starts, they are ready to get back to their activity. And also many of them, there will be children, athletes and sports loving children, or who are very up to the higher level of sports activity. When the children having a high level of sports activity, they have one question: when can I go back to my sporting activity? Generally, it take about 6 months. Generally, take about 6 months. So normal activity they can resume within 2 months, but higher functional activity like sports will take about 6 months. And sometimes, as every surgery is associated with few complications, but very, very rare, and second surgery for the implant exit may be needed. But when it comes to rigid disc planners, it's totally altogether a different spectrum. And good thing is very, very rare. And what is the main complaint that they present is one is the pain again. So these children have more pain symptoms than a flexible flat feet. And when they come with the pain, and when we take X-rays, we can see the association of few bones. Normally, there are about 26 bones within the foot and ankle, and these bones are separate, different particular multiple joints are there. But in this rigid plus planus, what happens is there can be a fusion of 1 or 2 bones, especially the ankle bone and the heel bone. We call the talus and the calcaneum. These 2 bones can get fused. It can be a bony fusion, it can be a fibrous fusion, it can be a very small strand, it can be a gross fusion. So there are different varieties. So we may have to see this fusion and to analyze that very clearly, we may have to go for a CT scan and a MRI scan. So once we see that, then we may go for a surgery. And the surgery is mainly to analyze that. So before surgery, even in these patients, even the children with rigid disc planners, you can try conservative treatment. If it is very painful, we can put them in a cast or a boot for about 6 weeks. We can give them a flexible middle arch. In rigid disc planners, we don't give a hard middle arch because it is already rigid. When we give a rigid middle arch support, foot will not be able to conform to the middle arch, and the child may feel more painful. So the better thing is to give a flexible middle arch of silicone material or something like that. And also the most important thing, activity modification. Many of them do better when you suggest them the activity modification. And when it is not effective, the conservative treatment is not effective, then you can definitely go and operate. Thank you. Now Mr. Ganesan will come and explain to us regarding various orthotics that are available, and also regarding the various exercises, including gastrocnemius stretch.
Immediately after that, we'll have some questions and answers. So if you have any questions, please type your questions on your page.
Yeah, come. Camera through.
Wait.
Go that side. You see the camera. Yeah. Good evening, everyone. Now I'm going to show you some small interventions what sir has mentioned. The first thing I'm going to show you is how to do a proper stretch for the Achilles tendon and stretch the gastroc muscle. Now, as kids, to make them perform a stretch is very difficult. Either the parents are going to perform them, or we are going to make some activities where we can expect there is going to be some stretches. Now, this is the point of area where we can find the tissues to be tight, particularly. So this is your entire calf muscle. So this will be tight, and the tendon, which is going to be very tight. Now, you can do a massage to these tissues with deep friction. So you can have some oil or cream, and then you need to go deeper and do a release, what we call as. So you're going to allow the tissues to expand and take that tension off. The same thing can be done on the muscle bulk on top, and this is more thicker tendon region. So this can go all the way down closer to the bone here. You can have some smaller areas either on the outer side or on the inner side being little more tight. That is fine. So you need to concentrate little more on them to get that tissues released. Now, how to do the stretch? So, as it was mentioned earlier, a calf stretch is given in the textbooks and in videos where you can see in a lot more way, where people just use something to add pull over here. Now, what we need here to understand, if it is a very flexible feet, that is when you will find this part going more outward very easily. So for those kind of kids, you need to have your hand lower down, fix it along with the bone what is protruding, what you can feel on the side, which is called as a malleoli, and then you exert it in a straight position. You have to make sure when you stretch, it does not go into the sides. It is maintaining a straight line. So you go on and you will find a stretch probably very close to the foot and above, and might go all the way up. That is fine. So as long as you know your foot is not wobbling off onto the side, then you are very straight. So remember, this is for the feet which is very flexible, flat feet, which is too much wobbly. So for them, for the stiff flat feet ones, again you might have to release, and then again see if they can maintain, just go about and stretch the calf muscle. So usually the parents are supposed to do this. There is another muscle called soleus. So when you want to stretch that, you can slightly bend your knee, and then you're going to stretch the same thing. So ideal position will be hold the hands down. You're going to allow the foot rest on your elbow and exert the pressure. So you can use your own body weight and push it down. The kids will start feeling a pain along with the stretch on the muscles, and they will try to wiggle off your legs. So you can try and support them, allow the stretch, try to hold it for minimum 15 to 20 seconds, and then you release. So this will be the stretches, how you need to perform for the kids. Now I'll show you some simple exercises, what you need to do. Okay, so we can try and get the kids to go up on the heel, try to stand. So that will be one which is going to help them down. Again, one more, go up and down. Okay, turn around. So turn a little more. Yeah, go up. So we want to see that how the heel raises up nice, curves in. It should not be curving in too much or being wobbly. Sometimes they'll find it difficult to balance, so they can hold the hands and down. Now let's do a toe walk. You can give this as an activity, making them do toe walk, few steps forward and back, turn around, and down. So that will be the activity. So, as mentioned, sometimes in conservative treatment, when there is symptoms of pain, they might need a insole. So there are pediatric insoles that is available for kids. So they come in different sizes. So this is a sample of that. So this is recommended when they are symptomatic. And kids, again, preferably those kids with strapped ones is better because that's going to give them some kind of a good support. So with the straps on, you pull it up and fix it up. So these kind of footwears are far better. And when they wear shoes, pediatric shoes, supported ones, so this should be hard. It should not be very soft. So it should be hard enough. So those kind of shoes are better for kids to go about doing their physical activity for symptomatic kids. So this will be some of the basic conservative management what you need to do for the kids. Thank you.
Thank you very much, Mr. Ganesan and Dr. Vidyasagar. You explained almost everything about flat feet in children, and we'd like to clarify some doubts from the audience. And there are one or two doctors, not many doctors. So we can be very basic. And the first question is, can the child with flat feet participate in sports? Can we push the child in sports if he or she is keen?
Yeah, definitely, there are a lot of elite athletes who have flat feet and who excel in their particular field of sports. So it is not a contraindication for any child who has a flat feet not to pursue sports, as long as they are not symptomatic. So push them, let them play. And only if they are symptomatic, we may have to go for an activity modification, change of the sport or anything. But if they don't have any problem, they can excel. There's no contraindication not to go for sports in case of children having a flat feet.
Do they have to wear the arch all the time or only while playing? Any thoughts on that?
They have to wear arch all the time if they are symptomatic. But if it is a painless, flexible flat feet, first of all, we don't prescribe any arches. Only if they have it's going into more valgus, deformity is increasing, and they have some pain by the end of the session of the sport. That's the only child, those are the only category of child we prescribe middle arch. If we prescribe a middle arch, it is better to wear all the time, even during the play and even during the daytime. But if it is painless, it's a flexible flat feet, there's no need for any arch support while playing or even while not playing.
Okay, what about dancing? Is there any dancing restrictions in a child who's very keen about Bharatanatyam?
Not really. Dance is also a type of sport. Not really. If they don't have symptoms, they can very well dance. No issues.
Right. So one person is asking, my child has got hallux valgus, 12 years old. What do you advise?
Hallux valgus sometimes is seen in association with a flat feet because of the hyperpronation. It may be more pronounced because of that deformity. It can be seen more. But again, the same thing. If it is painless, we don't operate in children in 12 years of that age. If it is symptomatic, child is having pain, then we'll definitely operate. And the treatment for hallux valgus is only surgical treatment. There is no other orthotic or any other conservative management. And for the cosmetic reasons, we generally don't operate, and we generally dissuade them not to operate. But if it is symptomatic, painful, we operate any age. Generally, it will be symptomatic only beyond 11, 12 years. And we can try conservative treatment. If not, we will definitely operate.
Okay, one question. How do I, you already answered this question. during your talk. But however, how do you make out the difference between rigid flat foot and supple flat foot?
Those are the two things, like as Mr. Ganesh also was showing, that you ask a child to stand tiptoe, and the arch should form on the inner side of the midfoot, middle level of the foot. If the arch is not forming when the child is standing on the toes, that means it is rigid flat foot. If the arch is forming while standing, it means it's a flexible flat foot. So on standing, just plain standing, the both rigid as well as a flexible flat foot, they look same. But when you ask them to do a tiptoe, or when you ask them to do a jack, that is, you just lift the toe, lift the toe, then the arch should form if it is flexible. And it is a rigid flat foot, it will not form.
Right. When there is no pain at all, when the child has got flat feet, should I still go for a middle arch support, or is not necessary?
It is not necessary, but many times, many general physicians, family physicians and general orthopedic surgeons, they do prescribe just to make the parents and the grandparents happy. But otherwise, of course, by using the arch support, there's no harm, but at the same time, you're not going to improve the arch. If it is not there in the child's genes, it's not going to come, you're not going to improve it by just wearing the arch support all the time. If one of the parents or both the parents, or there is a history of flat foot in the family, child may have the flat foot into the adulthood. By just wearing the middle arch support, you are not going to bring that back. But there's no harm in that. But I don't prescribe to my patients.
Good. I have a child, 4 years old, flat foot, and you're telling me to teach the child exercises. Go on. And which is the cutoff age beyond which will you say that it will not improve? Now, I need an X-ray for the investigations and maybe surgery. Which is the cutoff age? What are the criteria with which you decide when the child needs some definitive treatment?
Generally, we up to 6 years, we name it as a physiological. That means every child will go through that phase. The muscles will develop for the arch to be pronounced only after 6 years. So up to 6 years, many kids will have, some may develop by 4 years, some may develop by 5 years, some may develop by 6 years. So 6 years is the cutoff, generally speaking. If the child doesn't develop an arch by 6 years, that means they are going to have flat foot even into their adult life. That is the one thing. Second thing, if the child doesn't have a pain, or child is improving with conservative treatment, we will not operate. Operation is only planned or is only suggested only after 10 years of age, and that too if the child is symptomatic and it's not tolerating any orthotic and it's not improving with the conservative management. Children below 10 years, generally we don't operate for a flat foot. Even if it is symptomatic, we still try conservative management, change of the sport, change of the activity, changing the orthotic, like that. So it is a 6
one
years.
question here. Carry on.
Finish.
One question here. As a child, no treatment was given, and as an adult, and this lady and gets married and got children, and how often do they end up in surgery or treatment? So how many of them really develop pain? What percentage end up in surgery later on? What is the disability it is at that time? Can it be cured 100%?
Yeah, I mean, when the child comes to the clinic, I generally look at parents. If one of the parents or both the parents have a flat feet, I ask them how are they doing it. If they are in their 30s or if they are in 20s and they're still having no problem, or if the grandparents and they don't have any symptoms, I tell them that it's your same gene pool. Most of the times, most probably this child also may not have any trouble. But having said that, you asked about question about how much percentage. It is only about maybe about 5 to 10% of these kids may have symptoms. May in adult life also they may have some problems and they may end up having a surgery. That generally, as I told, it's about by first decade they don't have any issues. Second decade only they become more active and they may have some symptoms. So that's the time we may operate. But in adult life, during as a child having a flat foot, during adolescent age, not much of a problem. 20s, no problem. 30s, no problem. 40s, when we compared children, the patients who had a flat feet, the patients who had a flat feet during the childhood, adolescence age, and people who didn't have flat foot and developing an ankle issue or adult acquired flat foot, definitely the people who had a S planus in the childhood are equal almost. There is no exaggerated incidences that because you have flat foot during the childhood, you are going to have symptoms in adulthood. No, it is not proved. It is equal probability that you end up having the flat foot related problems in adult life than a person who didn't have flat foot during childhood.
If the person puts on weight and 30, 40 years old, and do they get into more trouble with the foot?
I didn't get the question, sir.
No, if see they tend to put on a lot of weight.
Yeah, definitely the weight, the obesity has definite correlation with regard to the ankle symptoms, with regard to not only flat foot, many other problems. See, when the patient is having pes planus, so and the obesity is added onto it, there's a higher chances that the deformity worsens and they go into valgus deformity. Definitely there is a correlation.
Thank you. In a child, say 2 years, 3 years old, is it no, or they are in the preschool area? Is it good to wear footwear, shoes all the time, or should they be left alone, free for a while?
I think it's better to leave them alone. There is no need to put them strictly that you have to wear shoe all the time or you have to wear particular footwear all the time. No. In fact, actually, many of the pediatric and foot and ankle surgeons, we suggest that leaving the feet free to walk on the bare ground, and that develops their multiple, various muscles and various movements in the ankle and the foot, than keeping them in the shoe all the time. But if the child is having a deformity, valgus deformity, and when the child is standing, the deformity gets worsened, such type of children, like especially when there is a neurological component is associated, that the children who's having the spinal problem or children who are having a CP or particular neurological problems, such kids, we definitely advise them to wear shoe all the time because the deformity is worsening. But a normal child who has just a flat foot around 2 years, 3 years, no pain at all, no symptoms at all. So we don't advise them to wear shoes at all. That is the parents are decided to give them a chappal or shoe, that is up to them. But there is no need to wear all the time just for the sake of to develop the arch.
Thank you. Is it good to make the child walk on sand, for example, seashore and all that,
Yes.
They believe that when the sand goes through the toes, they get a good feeling and a good strength and development to the feet. How true is it?
It is very much true, because when you are walking on a slippery ground like the beach sand or anyway, even on the gravel or anything, what happens is many of the muscles will come into action and those muscles will develop, those muscles will become strong, and that is the only way to improve the strength and the proprioception and the agility of the foot. Otherwise, if the child is always given shoes and always in the feet, so always in the footwear, sometimes you ask them suddenly to walk on the barefoot, they cannot. And they find it very difficult. So in that way, it is better to leave them alone, walk them, let them walk barefooted, let them play in the sand, even without shoes or without chappal or anything. It definitely helps in the development of the feet.
Thank you. Next question is, you are saying that very often this flat feet in children is congenital. So if you give proper treatment to the children and the foot develops arch, what is the chance of a relapse or reoccurrence of the foot for the child when it grows up, say 20, 25, 20, 30?
If with the conservative treatment, we are not going to bring back the arch, not at all. If the pain, it is a painless, flexible, flat feet, we can never make the arch reappear. That is very sure. We are not gods. We cannot make the arch reappear. But if it is symptomatic, or the deformity is worsening, then definitely we can operate. When we operate, when we do the boning procedures and muscle balancing, definitely 95% results we can assure.
Good.
And then most of them may not have any recurrence in the adulthood, the adult life.
One question, is there any relationship between hypertension and splenus?
No, I don't think so. I don't know anything that sort of relationship.
Right. That's a myth. That's wrong.
Yeah, it's wrong.
Is there any relationship between flat feet and knee pain?
Yeah, definitely there is a relationship. That's because when the foot goes into hyperpronation, that is, it is inwardly tilted, there is a higher stress on the inner side of the knee joint than the middle part or outer side. So the weight-bearing axis goes more onto the medial side, and thereby causing more, unbalanced stress within the knee joint. Definitely it has an issue, especially that we see in adults who develop sudden development of the flat feet, and they have already, if they have a little bit of component of the OME, they may have a worsening of the symptoms when they also have associated flat feet.
Adolescents, the young girls and boys, sometimes come with vague pain in the knee. And we call it anterior knee pain syndrome, because we cannot find anything wrong except maybe a little bit of pain under the kneecap bone. And on careful examination, they have flat feet. And then we correct the flat feet, the knee pain disappears. Because of, go on.
That's what the flat feet associated the tight gastrocnemius is also, it's a very, very important association that we always need to keep in mind when we are treating the, mind you, the gastrocnemius is a double joint muscle. It's acting both on the knee joint as well as it's acting on the ankle joint. It is hyperextending plantar thing for the ankle joint. It is flexing the knee joint. So unless you stretch the tendo-Achilles, it will have a bearing on the knee joint. So definitely they will have a pain in the knee unless you stretch the tendo-Achilles and treat the pes planus. It is associated.
And that was the last question. So we'll wind up this webinar and thank Dr. Vidyasagar, foot and ankle surgeon from Ortho1, and Mr. Ganesan, Chief Physiotherapist, for this wonderful chat. I'm sure a lot of audience benefited from it. I think next one is going to be next Saturday. The topic is going to be how to prepare yourself to get back to sports after this lockdown, because you cannot all of a sudden get back to sports. You'll enjoy yourself. We will tell you how to do it gradually. So thank you very much. See you then. Bye-bye.
Thank you.